Good afternoon, everyone. Thank you so much for being here. And I would like to thank AIOS for giving me this opportunity. So I'll be covering about the preoperative workup for a patient who is undergoing this treatment and how to choose ideal patients for your treatment. I do not have any personal financial interest. So basically it's a LASIK treatment. So we will be doing some tests which are a part of the routine pre-LASIK evaluation, like ruling out keratoconus and other things. Apart from that, there is a specific test called as Micromonovision test, which is a bit similar to our monovision acceptance testing, which is a separate thing which we have to do before treating with laser blended vision. So basically we do a subjective refraction and we do retinoscopy. For older patients we are not doing cycloplegic refraction, but for all hyperopes and the younger myopes, that is within 45 or so, wherever needed, we are doing cycloplegic refraction. Dry eye assessment is very important because most of these patients may have age-related dry eyes, and also they use computers, so it's we need to do that. Anterior segment evaluation in older patients, again specifically to look for lenticular changes, and of course retinal evaluation and ruling out other ocular disease is a must. Then in topography, again you would want to rule out any risk factors for LASIK, whether you want to do a femto-assisted flap or a microkeratome-assisted flap, and what would be the ideal flap diameter and method you would choose. Ideally, you would go for a 9.5 mm flap in a hyperopic or emmetropic eye, and in a myopic treatment by this software, you would want to go for at least 9 mm flap. So basically, the optical zone is a little bit larger than your regular wavefront optimized or guided LASIKs. And the software suggests you the optimum optical zone, but you can alter it slightly. So then aberrometry is to rule out any higher order aberrations beyond the normal limits. And another thing which it helps is to see the pre-existing spherical aberrations. The newer version, that is Presbyond, which is available now, is a software which allows you to consider the pre-existing spherical aberrations and modify it accordingly. So the Micromonovision acceptance test basically consists of 4 steps. So initially we correct the both eyes for distance, that is you make the both eyes emmetropic, and you also observe for the best corrected visual acuity, and then you check for the dominance, and after checking for dominance you give near add to the non-dominant eye, and while doing so don't make the patient aware, otherwise they will have a mental block and they will not accept it. Also explain the principle of the treatment after you do the testing. Also do the testing repeatedly, like a couple of times. What we do is when the patient first comes to us or wanting this treatment, we give an initial test, and then we give them a couple of days time to digest it, like this is what happens, and we demonstrate how one eye may be slightly blurred, because this is a monovision based principle. So the non-dominant eye will be very slightly blurred. Depends on person to person and the correction. So you need to say the similar things which you would talk to a monovision treatment patient. You tell them that you should not compare between both the eyes. But then it is a little different from monovision. I'll be going, as Sir said, there will be a increased depth as well. We cannot demonstrate that to the patient before the procedure, but we tell them if you can accept this, then you can very well accept the next step after treatment, because it will only get better. So then check the binocular distance and near vision and see if the patient sees any cross blur from the non-dominant eye. Also, can the patient read with both eyes open? So this is a video for the benefit of the learners here. As you know, there are various methods of dominance testing. This is what we do. So I'm just correcting both eyes for distance, and then checking the vision and asking the patient to make a triangular aperture with both his hands at arm's length, and give them a distance target and observe from which eye they are viewing the target. And then, so basically I would like to say that repeat this test couple of times. The patient also gets more and more familiar with what, and they get, once they accept it, that this is what will happen, they will adapt very well. So in this patient, I am occluding one after the other, both the eyes, to see which eye he is viewing the target with. And then you ask them to bring the aperture close to one eye, viewing the distant target. So here it is the right eye dominant. He is around 46-year-old. So right eye dominance. So we will be giving the 1.5 ad to his left eye and asking him to read. Can he read near and intermediate? Now, even if the patient is around like 55 or something like that, if you give 1.5, sometimes they can't read N6 before the surgery. Even if they can struggle and read N6, it's good enough because after surgery they can read N6. You'll be surprised at the amount of depth this treatment gives. You could go for a 1.75 in older patients, and in younger patients, 1.25 or 1 as required. So depending on the comfort in which they accept the test before the treatment, you need to adjust that. Other thing is, patient should not be aware again. This is similar to a monovision test. When putting the plus 1.5 on the non-dominant eye, you can occlude his vision from the vision chart. You can just come in the way and do it, or do it when the patient is looking at the near chart. So they will not realize what you have done. So after you put the distance correction, also show them the near chart. See, can you read? So they won't be able to read, and that is when they actually realize that, okay, one eye has to get blurred for me to read clear. Otherwise, they will not understand if we just tell them that. So this is the earlier software, that is the laser blended vision, and this is the present one available with some additional features. So after you get the manifest refraction of the patient, so what you do is, sorry, I can't show the pointer. So you need to enter the patient, the distance correction in both the eyes, and then this circle thing is where the software imports the data of the spherical aberrations which patient is already having from the aberrometry reading, and then you can import the topography and the pachymetry, and this is the optical zone. Usually it is 7 mm for emmetropes and hypermetropes. In myopes it is between 6 and 6.5. So that is what is ideally recommended, but you can go a little bit that way and this way depending on other factors like flap diameter and pupil size. So, and then you need to enter which eye is dominant and if the patient is accepting the 1.5 diopter test. If he doesn't, then you can check no over here and you can manually adjust the target. What we observe in this software also is that you needn't bother about how much spherical aberration to induce and all that. This the company has already given us based upon the nomogram. And the factors which they take into account are, one is the age of the patient, and second thing is the pre-existing refractive error. Usually a positive spherical aberration was noted in myopic corrections, and the other way, a negative spherical aberration was induced in a hyperopic as well as emmetropic patient. This was studied also, which Dr. Vikram will be covering. And then both positive as well as negative spherical aberrations do give depth. Yeah, so then if you see the target refraction in the end, it will be slightly different from the entry which we do. This is because of the changes made in the aberrations. And then you enter the software, you take it on the pen drive, the treatment, and then put it into your MEL 80 or MEL 90 excimer system as you would do in other treatments. So that is the treatment planning. And regarding the pre-op counseling and patient selection, as in any other presbyopic treatment, you need to do it yourself. Patient, when they speak to the surgeon or who is involved in this treatment, they get confidence and you can answer these questions. And also you need to make sure that people who talk to the patient say the same thing, and clarify their doubts. So explain about the principle of treatment and why the patient needs to accept some blur in the non-dominant eye. It will be of the order of like 6/18 to 6/9 in the non-dominant eye. That is what we have observed, which is again less than what a patient would have if they had a 1.5 diopter myopia. That would be around 636 or 624 vision, but you actually get better vision in the non-dominant eye. But they need to tolerate that much at least. So, and tell them not to compare between both the eyes. You need to repeat telling them this even after the treatment. And also what are the alternative treatment available, because they would have, these days they are well aware and you need to discuss with them which option is best for them. and also tell them what to expect post-operatively. What are the problems that they may face post-operatively? Some patients, especially hyperopes, do feel a little bit of blur from the, when you look to the non-dominant side, when you look to one side, or when the accommodation is coming into rest in the initial 1 month, they can see a slight occasional blur. So you need to reassure them that this is normal, but it doesn't hinder their day-to-day activities or anything. Ask about dry eye symptoms and profession and hobbies. It's important to ask about dry eyes because many of them use computers. If they know that it will get slightly worse, they again adapt better instead of them discovering it later. So profession and hobbies are very important in terms of how much ad you are going to give during your testing, and that again enhances the it improves the outcome. Assess patient expectations. What I usually do is just ask them, why do you want to undergo this treatment? And they come out with the actual reason. What we may assume is they don't want glasses, but they will have their own reasons, so you need to correct accordingly. So who is suitable for Presbyond? Based upon the refractive error, myopia up to 8.5 is what has been tested and you can do. It is similar to a regular any other wavefront optimized treatment actually, depending on their residual stromal thickness. You can go have the same criteria for this LASIK and it behaves in a similar manner. Myopia with presbyopia and astigmatism, with myopic astigmatism, do extremely well. They adapt very fast. What we have observed is our patients within 1 week they come driving and they do all their activities from the very next day. Though we tell them to go slow, take a month, see if you can drive and then go. But actually most of them adapt very easily. And then hypermetropes. Generally, you may wonder, though you can treat up to 5.75, any hyperopic treatment has suboptimal results in LASIK when it passes the 2.5 or 3 diopter mark. Especially in the non-dominant eye, you need to correct a little bit more. So for optimal results, it is up to 2.5 diopters. We have also done most of our cases are within this range. We have not tested the higher hyperopes because initially we started with the 42 to 49 age group when we started this treatment, and then now we have expanded. In terms of refractive error, up to 2.5 is what most of our hyperopes have undergone, but it does allow you to do up to 5.75. You need to explain to the patient that there may be a slightly increased rate of enhancement, like as in any hyperopic treatment, and there can be effects of regression. So they may have to wear glasses on a long run for near activities sometimes or accordingly. So hyperopes, till their accommodation comes to rest, they will have little struggle for distance, but then after 1 month they are quite comfortable. Emmetropes also do well. Again, emmetropes need to be counseled very well because one eye will go slightly blur, but the distance eye will retain its vision. So once they accept this mentally, like, okay, it's okay to do that, it's okay to create a little disparity, they will adapt well. And yes, treatment has to be done in both the eyes in emmetropes to get the optimal results. So age criteria, 42 to 49 would be ideal candidates as you expect because it's a 1.5 ad, and they have realized the problem of presbyopia. So they are the ones who will do well. And younger patients from 37 to 41, we have a few patients in this age group. You can reduce the target myopia to 1.25 or 1 or even 0.75 as required. You need to tell them that in future you may need some enhancement or some additional glasses. And older presbyopes also do well after this treatment, surprisingly, with a 1.75 ad, because if the patient is 52 like that, we have given 1.75 even after 50, and sometimes even after 46 we have given 1.75 just for the sake that the longevity of the treatment. So if it's okay with the patient, they don't use computers so much, you can give them slightly higher also. So with 1.5, 50-year-old will comfortably read N6, and there is no defocus after the procedure for near or intermediate. Lenticular changes you will be observing. There is no issues about night driving. The incidence of halos is same as your regular LASIK. So the profession and hobbies are important. Older people who read a lot, you need to go for slightly higher number. Only 2 patients we have corrected with +2 in the non-dominant eye. Otherwise, we've kept it 1.5 or 1.75. Very precise binocular vision required in some patients like goldsmiths and some professions. In these people, if you are going to do the treatment, you can give corrective glasses after the treatment. It's very easy to refract these patients. Unlike multifocal treatment, you will give the corrective spectacle for their whatever work they need to do. after the treatment, which they can use during that activity. So there are some unusual situations like pseudofix. This is a pupil size independent treatment. So even in small pupils, if you have a central pupil, if there are no major wavefront errors or higher order aberrations, you could do a treatment, and you may opt to do a 1.75 or 2 diopters. We have done a couple of patients. They're okay. And when there is unequal vision in both the eyes, so it's a very small difference between both the eyes, like 6 parts and 6. Generally, the better vision eye you have to take as the dominant eye, most of the cases. Some patients very rarely will not accept like this. We've had some 3 or 4 who had the other way around. They kept showing dominance testing other eye, but the vision on Snellen's is better. In those cases, you go according to the needs of the patient. And again, very wide disparity and amblyopia are not good candidates as in any monovision treatment. Then thin corneas, where we practice, there are a lot of corneas which are 450, 460, but they are normal. So some patients who were very keen, we have tried out surface ablation only in the non-dominant eye. The company does not recommend this treatment for surface treatments because again it's a complex treatment. We don't know how it will behave on long run. But we have done it in a non-dominant eye and they have behaved well. So we have around 11 patients now. Actually 10 of them have completed 1 year follow-up. And just in the non-dominant eye, we have used the same software and created 1.5. They enjoy distance as well as intermediate vision and are maintaining it. So the dominant eye, we have kept a regular wavefront optimized treatment and made them emmetropic because it's a surface ablation. Thank you very much.